Right. So we stopped at this point last week, right? We were talking about seizures in overdose patients, right? So like I was telling you guys, because drugs, whatever drug it may be, affects the brain, chances are seizures are going to happen, right? So the question is, what do you do? Just going to close the question. So the question is, what do you do? The honest answer is that you treat it like how you would treat any type of seizure. You don't stop treating it, right? So you most likely get tonic, chronic, right, seizures, because generally drugs diffuse themselves throughout the brain. But occasionally you can get focal seizures, right? Now, focal seizures tend to happen if there's a vascular component. Some of the drugs tend to lead to coagulopathies and things like that. So you can get, but it's not very common, right? So as we had gotten to that point, just laser point up, just stop it. Okay, so the question is, what do you do if you have seizures? So the management of your seizures is benzodiazepines, right? And more benzodiazepines and more benzodiazepines, as much as you need, right? So what are benzodiazepines? You guys already know what benzodiazepines are, even if you don't know it. You all have been there when we've given Ativan, Domicum, Valium, you know, all of these things. These are all your benzodiazepines. So the question comes about, what if your patient has a benzodiazepine overdose? We still give benzodiazepines, ironically, right? Because the only reason your patient would have seizures with a benzodiazepine overdose is if you're reversing them too quickly. In other words, they're coming almost into like an acute withdrawal, right? So you give them benzodiazepine, okay? And then we have what we call a status epilepticus protocol. So in other words, when the patient remains in seizures, there's other drugs that you can use. So there's things like etomidate, ketamine, propofol, ketofol. There's a lot of drugs that we can use to control seizures. We can use volatile anesthetics. Have you guys been into theater already? Okay, well, if you go there, you'll see there's a whole bunch of drugs that lie in canisters, sevoflurane, desflurane. There's a whole lot of these things. They're basically inhaled drugs. That's what goes through the tube to the patient to keep them under anesthetic. So we just give them the same thing in an ICU setting, and it tends to calm down the seizures, right? Now, the one thing, just by the way, absence of movement does not equal absence of seizures. Actually, absence of, you've got to have your patient up on an EEG and confirm that there's no spiking activity. That's what confirms that there's no seizures, right? Just by the way, right? That's just because if you, for example, paralyze your patient to intubate them, technically there's no seizures if you really look at them, but they may still be seizing on the inside. Okay. So the only exception for this is isoniazid, right? Have you guys been through the TB section at all? All right, so isoniazid or INH is given as TB prophylaxis. All right, so to those family members who are living with somebody who's got TB, in order to prevent them from picking up the mycobacterium and things like that. So as far as I know, we have more than 2 or 3 patients. All right, there's thousands, hundreds of thousands of patients, even in our district of 4 million people. We are, I mean, just in Amajuba, literally, I'm not joking when I say we have hundreds of thousands of people on TB treatment. So you have more than that on isoniazid, all right? Now, isoniazid is a very good drug. The problem is that because it's so easily available, it's one of the things that is often overdosed on, right? And these patients, one of the things that they come in with is seizures, actually, right? Now, as I was telling you guys at the start, most of the time, your patients will come in or the paramedics will come in and give you an idea of what was taken. Let's say, listen, we found this, this, and this. So even if you don't know specifically, but maybe you have a choice of 3 or 4 drugs, or, you know, you can see, okay, maybe they fall into this syndrome or they fall into that syndrome. If your patient comes in with seizures, particularly, I would always suspect isoniazid poison, right? The problem with isoniazid, just as little as few as 4 tablets, which is not much. I mean, they give them out in batches of 30 or 60. 4 tablets is actually not a lot. So 4 tablets can actually lead to toxicity. But most patients are not going to overdose and count 1, 2, 3, 4. Okay, now I'm going to be toxic. No, they just down a whole bottle. You know what I mean? So they tend to come in extremely sick. Now, the one thing that happens with these patients is that when we see, and I always advise everybody, whenever you see a patient that's fitting, you have to do a blood gas anyway. And what will happen with these patients is that you get a severe increase in the lactate, all right? So lactate normally sits at about 1, less than 1, Okay, if your patient's hypoxic, very hypothermic, has a limb that's dead, it goes up to about 10 or 12. If your patient's got a carcinoma of the breasts and it's metastasized and things like that, you may find it sitting at about 17 or 18. And these patients often have lactates of 27, 29, 30. So it's an extreme increase in the lactate. And that's actually one of the biggest clues that this could be isoniazid poisoning. All right. The other one is metformin, but that's another thing altogether. All right. So the question is, what do you do? Because now if you give them benzodiazepines, unfortunately, they're not going to resolve. Okay. So I want you to just remember this. When there's isoniazid, you give pyridoxine, vitamin B6, all right, pyridoxine tablets, which are also freely available in the hospital. All right. And we give it on a gram-to-gram basis. So that means if we knew the patient took 1 gram, we give them 1 gram of pyridoxine. They took 1.2 grams, we give them 1.2 grams of pyridoxine. The problem is that very often we don't know exactly how much the patient took. So what we do is we give 5 grams if you don't know the amount of isoniazid taken. Now that sounds very simple, but pyridoxine doesn't come in 1 gram tablets. It comes in 25 milligram tablets. In order for you to give 100 milligrams, you have to give 20 tablets. So for you to give 5 grams, you have to give 100 tablets. So you can't exactly sit there and just pop tablets into this patient, all right? So in fact, if you go to some of the bigger units, they actually have specialized things that they use, all right? But anyway, so what we do with these patients, most of them will be intubated, all right? Because they are out of it. They are severely acidotic, their GCSs are low, they've got this extreme lactate, they're hypoxic and things like that. So you've already got a tube down their throat. Now you pass a tube into their stomach, a nasogastric tube. Now you collect all of these pyridoxine tablets and you get the most junior person in the department, unfortunately one of you guys, or new nurse who came, somebody, and you give them a little tub with water and something to grind the tablets. And they got to sit there for 10 minutes and just grinding. And they you kind of make like a paste out of it. And then we give that down the nasogastric tube. All right. So that's the only way to give it, unfortunately. If your patient's taken like 4 tablets, they're still relatively awake, okay, you can give them a few, but majority of them come in quite sick. All right. So remember this, even if you can't remember exactly how it happens, or if you forget this in 3 years' time, you're working as an intern, but just remember, isoniazid, INH, shit, I give pyridoxine. Then you Google it, all right? And you remember everything will come back to you, all right? How to treat isoniazid poisoning, and you will save the patient's life, okay? So please remember that. The simple reason why I mention it is that if you don't, you're going to keep on giving them benzos, but you're not actually treating the problem. Acidosis is getting worse and worse and worse and worse. Now, the pathophysiology behind this is very interesting. Not severely complicated, but it'll take a bit of time to explain. So we're just going to skip over it for now. And if you have a chance, go and read about it. It's actually quite interesting to see how isoniazid actually causes this acidosis. Okay. All right. Now, hallucinogens. The patient was just high. All right. Just absolutely high. So this we see normally with things like magic mushrooms, peyote. There's all these types of drugs that you take, right? Some of the newer designer drugs, things like even ketamine, things like that, right? So this is a hallucinating patient with disorganized behavior, all right? So they seem like they are psychotic, okay? And we don't actually have a way to test. I mean, in first world countries where you can do big tox screens and all that, pick it up quite easily, but we actually don't have. So a lot of these patients will come into us that we are admitting for 72-hour observation. We actually be taking some of these things because I understand these mushrooms are not that expensive. I mean, they're not that cheap either, but I mean, they're not that expensive, all right? So, and the unfortunate part of drug addicts is that they're always looking for the next high, you know? So if something is not available, they're very willing to try something else, you know what I'm saying? So we tend to get these types of things. Now, these patients, they don't generally overdose to the point that it's fatal, all right? They overdose to the point where they are completely disorganized. You can see this person is just high, you know, they're in their own world, that's for sure, right? And really, if you have a chance, sit with them because they give you the best stories. Honestly, they give you the best stories. I remember having one guy when I was working in psychiatry as a student. They had him over there as a chronic user, and he would tell me about how there was this dragon that was chasing him on the roller coaster, and you get all these things, right? So the only 2 things that you do get generally with them is agitation and hypertension. Can be caused, right? So the hypertension is 2, There's a physiological hypertension caused by the drug itself, and it's also related to the spike in adrenaline from the experience. So whatever they're experiencing during the hallucination or during the high also leads to it. So the best way to treat that is with TNT, right? Sublingual, rather than giving them drugs like amlodipine or HCTZs and things like TNT works better. And then your benzodiazepines for agitation, which we would normally give because, like I say, they appear psychotic. So you give them, your Ativans and Valiums and things like that. Now, the unfortunate part is in most of our departments, we are quite busy. We don't have the time to listen and, get the full history. So they normally are treated as psychotic patients. They end up in their wards. And then as they start to detox and come off the drug, then suddenly this patient wakes up and is like, where the hell am I? What's going on? I was having fun and now all of a sudden I'm sitting in a ward. You know what I mean? So that's generally what you find. Okay. All right. So we're going to go through some specific topics. All right, now I'll try and cover as many as I can. Unfortunately, we did start a bit late, but we'll try and get as far as we can, and hopefully we cover a few of them. All right, so when I say OTC, over-the-counter medication, all right, so paracetamol, all right, one of the most commonly used drugs in overdose, right, which we'll get to. Now, the thing is, you must suspect it in any unconscious overdose patient. The reason being, it is potentially lethal. It is potentially fatal. Okay, so where you don't have a history of what drug is taken, your patient is unconscious and cannot confirm what drug they have taken, always take paracetamol levels. Just do it. And take your liver function test. Just as a matter of course. In other words, it must always be in your mind. Now, majority of these patients who overdose purely on paracetamol will tell you, I've taken paracetamol, this many, still pain, Flustat, there's a whole lot of them. There's a whole lot of drugs that contain paracetamol, but any paracetamol containing compound, you should be worried. If the patient is jaundiced, that's already worrying. That means this has gone quite far, all right? And like I say, if there isn't a clear history of what was injected. So as I say, sometimes they come with a whole lot of boxes and you'll find this drug, that drug, that drug. And if you see paracetamol in the mix, always assume that paracetamol was taken to be safe rather than sorry, okay? So the thing is, paracetamol is a long and complex topic, all right? I'll try and break it down just a little bit. Basically, what happens is that you have 3 zones within your hepatocytes, all right? Now, one of these zones is particularly sensitive to paracetamol, and it starts to break down very quickly. And unfortunately, this zone is the zone that is most needed in terms of liver function. Right. So when you have a chance to go and read about hepatocytes, zone 1, zone 2, zone 3, acina, paracina, all right. And what's the other one? Perilobula or something. I don't know what it is. So what happens is the paracetamol goes inside and essentially destroys the main part of your hepatocyte. So you start getting the release of all the enzymes. Like anything, when your heart gets destroyed, it releases enzymes. When your liver gets destroyed, it releases enzymes. So there's a few things that happen. Your patient is now unable to detox anything else in the body. They go into acute liver failure. Right, that's the thing. So the way that you have to look at it now, there's actually what we call a paracetamol normogram, which is very good if you have a real nice laboratory, which none of us have in South Africa. Maybe if you're at Albert Luthuli or something like that. So what they do is they actually plot your paracetamol levels, and then you've got to plot it against the normogram, depending on the hours and things like that. And if your patient falls above, you know you have to treat. Your patient falls below. I never present that because we don't have access to it. Our paracetamols go down to Albert Luthuli, they come back 1 week later. So your patient's going to be dead by that time if you wait for that, right? So the most important thing for us is actually the LFTs, liver function, right? And everything that goes along with the liver function. So your liver also controls clotting. So your PT-INRs, you've also got to look at that. Your liver also controls gluconeogenesis, all right? Glycolysis, things like that. So your patient can become hypoglycemic very easily with this as well, all right? So remember, patient comes in, you don't know what they've taken, or they've taken polypharmacy, in other words, a lot of drugs. Take paracetamol levels and assume that paracetamol has been taken, all right? If you can get an LFT quickly, it would actually guide you as to whether you should manage that, all right? However, if your patient has taken even 10 to 15 tablets, adult, right? Children even less. So it depends on age. You plot it against age, it will give you the exact, but in kiddies, let's say 5, all right? But in an adult, 10 to 15 tablets can be fatal. Remember that, right? Next time you've got a headache, 8 tablets maximum for the day, right? Now I'm just telling you. And it's normally parasuicides. The reason being, Panado is safe. It's the GP's choice. Agreed? what can be dangerous about this? I want the world to know my pain. I want the world to know that I'm suffering, but I don't really want to die. So what's my best bet? Grandpa, Panado, Disprin, all of which can ironically kill you. All right. So the patients take it and they come in. And a lot of them are very surprised when they say you turn white because you realize how serious it is. And suddenly you're getting CVP packs ready because you can't get a drip in. You're phoning the lab, you're phoning here, you're trying to get it. They're like, what the hell is going on? I just took Panado. Then you've got to explain to them the liver's going to shut down. They're like, oh shit. Yeah, that's what happens. I'll be honest, right? Patients don't actually realize it. And the treatment is within acetylcysteine, right? Paradote, there's a whole lot of names for it, right? Now, the actual treatment of it, I'm going to tell you now. You will forget it. I'm telling you, you will forget it. But remember the name at least. And the reason why I say is because we can all Google. Just make sure you've got data on your phone, right? Now, the way that we treat it in the A&E is that we give 150 milligrams per kilogram, right, of the patient. Yeah, and we generally give it in glucose, all right? If worse comes to worse, we do mix it with others, but ideally you want to give it with glucose. And we do have glucose available 99% of the time. All right. So when I say 150 milligrams per kilo, and why I'm specifying this is because when people work it out the first time, and I've had it with a lot of doctors phone me, like, this can't be right. Because suddenly I'm talking about 9 grams, 10 grams. I'm giving 8 vials, 7 vials of this shit. I'm working it out incorrectly. No, you're working it out correctly. The patient actually does need that much because this would work. So let's take 150 milligrams on a 50 kilogram patient. How much does that work out to? That's about 7.5 grams. All right. I wasn't very good at math at school. Don't worry. I learned how to do all these things. So it's about 7.5 grams. And each paradote will come as about 1.5 grams, sometimes 750, depends on which. So you're giving quite a few vials. You're giving 7, 8, 9 vials sometimes. So you may think, oh God, I'm doing this wrong. In fact, if you're only giving 1 vial, there's something wrong. All right. So that's why I specify that. Remember that. Okay, you've got to give a lot of acetylcysteine and you've got to give it relatively quickly as well. Right. So it's over about an hour or two. Right. Now, when I say an hour or two, there are specifics, but because sometimes you don't have an infuser, you don't have the ability to control it, you don't even have a dialer flow, especially in some of the smaller hospitals, but try and give it as quickly as possible. Then after that, there's 2 more doses that are given. One is given at 50 and then another one is given at 100 milligrams, but that happens later on. The first thing is you're trying to control this immediately as it happens. Okay. All right. Good. So salicylates. What are salicylates? Aspirin. Okay, let's see, what's the time? 8:46. Okay, so we can go through this. So again, aspirin, regarded as relatively safe. Aspirin should not kill you. Agree? Because you can buy Disprin at your local garage. You can walk in there and just buy a pack of Disprin, 30 inside, double strength as well, and it's no problem. Agree? So why should this kill you? And that's why it's another one that's often found in parasuicides. Now, the thing is with salicylates, it gives you a very particular picture. So it gives you a respiratory alkalosis, right? Now, when we say respiratory alkalosis, what we mean is that on your blood gas, all right, carbon dioxide and bicarbonate are the opposite of one another. So in other words, when one goes up, the other should come down. When the other one goes down, the other one should come up because they counteract each other's effects. So what happens in these patients, they get a respiratory alkalosis. What that means is that carbon dioxide is acidotic. So if it goes up, you become more acidic, and if it comes down, you become more alkaloid. So in this case, we get a low PCO2, respiratory alkalosis. So what we'd expect is for bicarbonate to go up in order to counteract that. But actually what happens is our bicarbonate comes down. So in other words, we have the 2 of them no longer counteracting one another. Now, again, this is something that you'll forget. But when you get one of these patients and you do a blood gas and you look at that, and you'll be standing there at 2 in the morning, and you'll be wondering, oh God, what the hell is going on? Okay, yes, Ernesto. Oh, I see he's talking about the acetylcysteine. Yeah, it can happen. Sorry, I didn't see the chat before that. So what I'm saying is it's an odd presentation of a blood gas. Generally, these patients, well, I'm going to show you what they present with, but you will normally have a history, but they have such a particular presentation that you won't really forget it, all right? And the one thing about salicylates, it can be acute. So acute overdoses tend to happen in a young patient, parasuicide, and it's a large amount taken quickly. Chronic overdoses tend to happen in our elderly patients. They've been taking Disprin, Grandpa for a long period of time, and they've been slowly but surely building it up in their system. And then they suddenly end up as how we're going to see just now, right? So what do these patients look like? So this is what they look like. Restless, irritable, excessive and unorganized talking, fear, dizziness, confusion, abnormally excited mood, hallucination, drowsiness, loss of consciousness, uncontrollable shaking. Aren't you already getting your forms ready for 72-hour admission? Agreed. So basically, they look crazy. They look crazy. All right, that's what the patient looks like. Then there's a few other things. Double vision, seizures can occur, burning throat pain, vomiting, pain in the stomach. There's one or two others that are not mentioned here that I'll get to now. So in other words, this patient looks, for all intents and purposes, like a psychotic patient. But there's a few things. Number one, the patient tends to be quite warm. All right. Patient, or I'll get to it in the next slide, but I just wanted to point this out, that this patient looks crazy. So if you have an elderly patient who comes in with signs of psychosis, don't you think it's worth it to do a blood gas? What if this gogo, who's got arthritis for many years, has been taking grandpa because that's the only thing that helps at night, and after 20 years of grandpa, at the age of 70, she suddenly presents with psychosis, which nobody does. Nobody becomes psychotic at 70 years old. So it's something that you need to look at. So the reason why I point it out is in young patients, it's not the end of the world. If they come in and you suspect psychosis and you admit them and it turns out later it was an aspirin overdose, there will be signs and things that you can go to see. But in an elderly patient that presents with psychosis, there's no harm in looking for other causes. In fact, in an elderly patient, psychosis should be your last differential. In other words, you've excluded everything else. Come in. You've excluded everything else, and then you come to it. All right. So just remember that aspirin overdose, chronic overdose, is also a differential, although I put it lower than infections. Acute infections are more common, but aspirin should also be there. So some of the other things that we get, nausea, which we mentioned, pyrexia. So that's the other thing that you get that may even point you towards infection in an elderly and might take you away from psychosis in a young person. Tinnitus. Do you guys know what's tinnitus? Yeah, continuous ringing in the ears. Hyperventilation. All right, that's the reason for the respiratory alkalosis. They keep on breathing out their carbon dioxide. Right. This is often the problem, hypokalemia. So again, the pathophys behind the hypokalemia is very interesting. It has to do with renal function and things like that. If you have a chance, we can read about it. It's a whole lecture on its own. But the hypokalemia can be very drastic. So this patient can go from normal to almost zero, can start having fibrillations and things like that. And when we have had these patients, we have to keep them on large doses of potassium over a long period of time, because every time you replace, they just drop. You replace, they drop. We have to keep on monitoring their potassiums. So these patients need to be monitored in an ICU setting, right? So they have gastric outlet obstruction, because what happens is that the tablets just clump together and they just block the outlet, all right? So you have to do CMPs as well. You have to look at calcium, magnesium, phosphate, serial ABGs, and of course, for clotting. Okay, so yeah, management, sodium bicarbonate. We're going to stop here, don't we? So I can see all yawning, Shem. It is cold. No, it's not you, all of them. Even I'm feeling like yawning, so it's fine. All right. Now, these are a few other things. So sodium bicarbonate, right? Potassium, right? And like I say, they often need serial levels and replacement, supportive management. So you have to sedate them sometimes, things like that. And the other important thing is fluids, right? So some patients, especially those in severe acute overdose, they may be 4 to 6 liters behind. Like I say, the pathophys behind all this is very interesting, but it's like literally we have to sit for an hour. We have to go through physiology and then pathophysiology and then get into how things happen. So I don't like to concentrate. Now, in saying all of that, in 3 years or 4 years' time, when you guys now, you'll have written your boards, you'll have your internship, you're sitting at Yusuf Dado Hospital there in Krugersdorp or something, and one of these patients comes in, you will forget. I know it will forget for 2 reasons. Number one, it's been a long time since you heard it. Number two, there's panic that sets in, right? Especially when you're a junior or you don't deal with this all the time. So do you have anything that you can do? Yes, number one, you can. That's right. How's the patient doing? No, it's fine. Yeah. Yeah. Well, we started the sodium bicarbonate. Let's do an ECG as well. I'm almost done. I'm going to come there now. All right. Okay. Yeah, so like I said, I've got an overdose patient in the emergency department at the moment. All right. So you have the tox center, right? So keep the tox center number on your phone, right? Afritox, right? Poison center, poison control. Number two, if like us, you have Afritox available on the computer. Not at the moment, I have to still set it up. They went offline, now we have to get the online one. But these are resources that you have. The simple reason being there's so many drugs that a person can overdose on. And all of this information, I mean, I've broken all of this down over 4 weeks, but we still only just touched the surface. We haven't even scratched the surface. We only touched the surface, right? And to become a toxicologist, to work at the Tox Center is another 3-year degree, post-grad. So you're not even a super specialist, you're super specialist to become a toxicologist, right? So it just shows you how in-depth and how scary it can be. But if you remember your basics, then you should be okay. So we're going to stop here now. There are 1 or 2 more, and we'll cover that next week because I've got to get to a meeting just now. Yeah, like literally in 5 minutes. All right. So we'll cover them again next week, and hopefully that will be our last one. If there are any questions, you're more than welcome to ask me and message me and things like that. All right. Otherwise, I'll post this to the group so you guys can always have a record of it. Okay. All right. No problem. Right. Bye.